My name is Hardeep Kataria, and today we'll be talking about eyes on regenerative medicine, biologics for dry eye disease. I have financial disclosures are listed here, and they're not related to the content of this talk. So the course objectives today, we'll be talking about biologics for the treatment of dry eye disease, including amniotic membrane, nerve growth factor, and blood-derived eye drops. So much of our discussion today will be based on an understanding of the corneal nerve anatomy. So we'll start with a brief review of the nerve pathways. We'll then review the advantages and the applications of dehydrated and cryopreserved amniotic membranes, the differences between them, and then hopefully we'll be able to view a short video of how to insert the membranes. Nerve growth factor is indicated in corneal nerve regeneration, and now that we have an FDA-approved treatment for that, we'll be reviewing that, as well as blood-derived eye drops, and touch briefly upon the future of biologics in dry eye treatment. The main goal today will really be to take away an understanding of the role of biologics in dry eye treatment and how to implement that into your dry eye protocol. And then one thing that I will do a little bit differently in this talk today is to do some pop-up clinical pearls that hopefully you'll be able to implement come Monday into your clinic. So please stay tuned for those as well. So I'd like to start with a poll, and we'll discuss the results of this poll during the Q&A. And my question to you is, which biologics do you most frequently use for the treatment of dry eye disease? Is it the dehydrated membranes, the cryopreserved membranes, human nerve growth factor, autologous serum eye drops, or PRP, which is platelet-rich plasma? All right, so we'll go ahead and progress here. So corneal nerves, as we all know, they originate from the ophthalmic branch of the trigeminal nerve. They enter the cornea at the limbus, they lose their myelin sheath, do that 90-degree turn, and then form the subepithelial and the subbasal corneal plexi. The cornea is so densely innervated that it's actually thought to be 300 to 600 more times sensitive than our skin, which I think is absolutely extraordinary. The corneal nerves support the epithelium, and the epithelium support the corneal nerves, and that's through the release of neuropeptides and nerve growth factor, which assist in corneal nerve healing as well as corneal epithelial healing. The trigeminal sensory system triggers input into the facial motor branch, which triggers what we know as the blinking reflex arc that facilitates tear distribution over the ocular surface and also tear drainage. It also triggers then the facial parasympathetic branch, or the tearing reflex, which in turn elicits mucin production, aqueous output from the lacrimal gland, and meibum release from those meibomian glands as well. So it's really an integration of those two reflex arcs that's vital in maintaining the ocular surface. When there's damage that occurs, whether that's mechanical or inflammatory, it's essentially interrupting these reflex arcs and interrupting that ability of the epithelium and the corneal nerves to heal. And then when that system is off balance, that's when things start to break down on the ocular surface. Damaged corneal nerves and corneal epithelium cannot provide that mutual support that they need to support to each other. And then, of course, the system starts to break down. So maintaining homeostasis is obviously important when it comes to the ocular surface. And it's so much more than just balancing tear osmolarity and MMP9. It's blinking, it's tearing, it's growth factors, it's neuropeptides. So it's really a balance, a delicate balance between the corneal nerve health and the health of the corneal epithelium. This diagram illustrates that support that the corneal nerves lend to the epithelium and vice versa. They provide the wound healing, the support for the wound healing. They help to maintain anatomical integrity. They release those neuromediators as well as those growth factors. Of course, then we also have the blinking and the tearing reflexes that comes from our corneal nerves as well. And then we have our corneal epithelium, which releases neurotrophic factors to support that healing, and therefore we have a two-way street. This non-exhaustive list of neuromediators on the left here illustrates those neuromediators that are released by the corneal nerves and the neurotrophic factors, including nerve growth factor, which is released also from the corneal epithelium. What I want you to understand from this slide essentially is that they activate each other to produce cytokines, neuropeptides, and neuromediators, and that is what facilitates that corneal healing. So any damage to the corneal sensory nerve impairs that epithelial healing and vice versa. And that's when we really start to see a breakdown of the ocular surface. And it might just be more than dry eye, and that can even lead to neurotrophic keratitis, which we'll talk about as the lecture goes on. So with amniotic membranes, amniotic membrane is the most extra embryonic tissue that surrounds the fetus in the amniotic fluid. And the membrane actually provides protection against infection and trauma. And the amniotic membrane that's for our use is derived from the innermost layer of the placenta. It's very highly metabolically active. And again, it provides that protection. To make an amniotic membrane for our use, it's typically donated and extracted from healthy cesarean pregnancies. It's then preserved and frozen, hence cryopreserved, or it's freeze-dried and preserved if it's the dehydrated version. The healing properties of these devices make them a fantastic opportunity for healing the ocular surface when it comes to acute corneal disease. The stroma is rich in growth factors such as TGF-beta, nerve growth factor, keratinocyte growth factor. It's also rich in different types of collagen, which are also indicated in corneal healing. The basement membrane resembles corneal epithelium basement membrane, and it can serve as a scaffold for limbal stem cells as well. The HCHA-PT3, that stands for heavy chain hyaluronin pentraxin 3. And essentially what that is a proteoglycan matrix that's unique to the cryopreserved amniotic membrane. This unique matrix is only found in amniotic tissue itself, so it's not something that humans are producing throughout their lives. And its presence is thought to be absolutely key when it comes to accelerating the healing process as it relates to corneal nerve regeneration. The properties of the amniotic membrane include acting as a bandage contact lens. And when we talk about the cryopreserved and the dehydrated membranes, they are actually approved as a device that acts as a bandage contact lens. The cryopreserved membrane is additionally approved for its anti-inflammatory properties. And that's its interruption in the inflammatory pathway, its ability to induce apoptosis of neutrophils and monocytes and macrophages, and also suppress T-cell activation and inhibit scarring. It's also shown anti-angiogenesis properties as well to help reduce corneal neovascularization. There are other biologics that I'm sure are coming to your mind as you're reading over this slide that are rich in nerve growth factor that help with corneal healing, such as autologous serum. The one thing that I love to point out here is that both are excellent options when it comes to corneal healing of the nerves and of the epithelium. When I apply an amniotic membrane, I am essentially trying to stabilize that cornea. So I'm going to apply that membrane for somewhere between 3 to 7 days, and then maybe follow up with other biologic treatments that are rich in nerve growth factor, such as autologous serum. And then, of course, a secondary benefit of placing a cryopreserved membrane here is that when you have no tape tarsorrhaphy, it actually helps with blinking in the fellow eye, which can help stimulate the tearing and the blinking reflex. So when we talk about the two types of amniotic membranes, we're talking about the dehydrated and the cryopreserved. The biggest difference here is the lack of that HCHA-PTX3, right, which lends structural integrity and significant healing factors. Now, we know from studies that the dehydrated membranes are just as efficacious when it comes to treating corneal disease. There are some significant differences in terms of other factors, such as storage and preparation, insertion, and cost. In the dehydrated membranes, they can be a little bit more accessible, in my experience, to the doctor and therefore the patient. The cost might be a little bit less. They don't have to be stored in a freezer. They can be stored on the shelf, and they can last up to about 5 years. They are still very, very rich in that nerve growth factor, epidermal growth factor, and others. And they can certainly be a great option for your patient. You do have to place a bandage contact lens to hold that dehydrated amniotic membrane in place. And then I always recommend following up with prophylactic antibiotics as long as that bandage contact lens is in place. With the cryopreserved membranes, you do have to store them in the freezer, and you do have to rinse them with some saline as you are preparing them to insert them in the patient's eye. There might be some difference in the cost depending on where you're getting those from. And they are actually preserved in an antibacterial, a fluoroquinolone specifically, and an antifungal. So you do want to make sure you're watching out for allergies in patients as well. The one thing that doctors always ask me, well, is that large PMMA 14 millimeter ring in the cryopreserved amniotic membrane uncomfortable to your patient? And what I like to do to combat that discomfort is always perform a tape tarsography. So the patient essentially will have his or her eye closed throughout the duration of the treatment. And I find that very, very helpful. And I let the patients know in advance what to expect. And I have had great success with both of them. My clinical pearl here is that, you'll hear lots of different feedback from doctors and colleagues. And what I would say is you really should just try both of them in your clinic and decide what works for you. There are certain techniques when it comes to applying the dehydrated membrane. Do you want to use a lid speculum? Does that work for you, for your staff, for your patients? And then, of course, issues with storing the cryopreserved. So you really have to try them both and then decide for yourself. And that's how I did it a few years ago when I was trying to figure out what would be best for my patients. For the indications for use, there are many when it comes to amniotic membranes, and this is obviously a very non-exhaustive list here. Severe dry eye, SPK, especially that persistent, very stubborn SPK that might be more leading towards neurotrophic keratitis, filamentary keratitis, corneal ulcers, active corneal ulcers, whether they are bacterial or herpetic in nature, recurrent corneal erosions, corneal neuropathic pain, limbal stem cell deficiency as well. Most of these indications listed here, I've been able to very successfully use an amniotic membrane for. The one thing I will say about the filamentary keratitis is that I do find it helpful with the very large filaments to debride the filaments, even with a cotton tip applicator, prior to inserting a membrane. And I think that can be very, very helpful. Any corneal surface irregularity might cause high order aberrations, and reports have demonstrated changes in corneal topography with the use of an amniotic membrane, and therefore improvement in those high order aberrations, and sequentially an improvement in the patient's vision. Another clinical pearl here is that you do want to make sure you are treating those comorbid conditions on the ocular surface. So treating those underlying cause of dry eye will be very important. This is here an example of a patient who had an interesting presentation of a very kind of persistent interpalpebral SPK on the cornea, staining on the conjunctiva. There was some meibomian gland dysfunction there as well. I personally chose to place a Procura Slim that's made by biotissue on this patient. So that's the cryopreserved amniotic membrane. I placed this membrane in this patient's eye for 1 week with a tape tarsography. So placing a piece of tape to kind of weigh down that lid so the patient's not blinking on that ring. Her results were maintained for about 2 months after the placement, which is about average, I think, for the device when I am employing it in my clinic. Some reports have certainly gone up to 4 months where these results will last, which is absolutely extraordinary. Again, a really excellent option for your patients. I did put this slide in here. I thought this clinical pearl was very important. I have seen this in clinic happen. Sometimes when a membrane is removed in the middle of treatment or even at the end of treatment, even though it's slightly cloudy at baseline, it actually might be very, very cloudy, almost white or opaque upon removal. This is not an infection. This is representative of inflammatory material that's coagulated on the front of the lens or the membrane. And typically what I'll do is go ahead and replace that membrane if my treatment hasn't completely healed, or if it has healed, then you're going to go ahead and remove that membrane anyway. I also, another clinical pearl, I typically have patients continue any necessary topical medication. So any of those IOP lowering drops that they're using for glaucoma, I will have them continue. It's actually quite easy because the superior lid, you're going to perform that tape tarsography, but the inferior lid, you can kind of wiggle in and then place those eye drops in. Warm compresses, lid hygiene, things like that, I will have the patient discontinue until we have completed the course of the treatment. So what is the data that supports the use of an amniotic membrane and corneal nerve regeneration? Well, this article was published about 4 or 5 years ago, and it actually showed that the corneal density and sensitivity of the cornea improved up to 3 months after placing a cryopreserved membrane. And that was just 3 days after treatment. The signs of corneal inflammation were improving, the symptoms for the patient, the conjunctival hyperemia, and that lasted even up to 4 months after the treatment. So I think that amniotic membrane is certainly playing a very large role when it comes to healing the epithelium. Not only that, but also facilitating corneal nerve regeneration as well. And some reports have even shown that patients become less dependent on eye drops after the use of an amniotic membrane. Those eye drops might be artificial tears or autologous serum or cyclosporin. Typically, another clinical pearl here is that I don't pull patients off of eye drops and immediately after removing that amniotic membrane unless I am seeing a prolonged improvement from the placement of that membrane. So just something to think about there. Another case example here, this was a patient who had suffered a Bell's palsy with an inferior lag ophthalmos of her right eyelid. And so I placed an amniotic membrane, a cryopreserved amniotic membrane. You can see this huge improvement, right? So this patient has exposure keratopathy from not being able to close the eyelid, a reduced blink. She has a very typical staining pattern, interpalpebral and also denser inferiorly. This is certainly affecting the patient's vision. I placed this membrane in here for about 7 days for this patient, had her come in, remove the membrane, and saw about 95% improvement. Now, of course, we are treating the underlying cause. This patient will eventually need surgical intervention. This can be a really great option to help stabilize the cornea until you're able to implement some of those more long-term treatments for your patient. So again, clinical pearl, make sure that you're treating the underlying cause. So what is the future of the use of amniotic membrane? Well, currently it's recommended as a step 3 treatment. And what I would encourage you to consider is this really appropriate as a step 3 treatment, or can we bring this in earlier into your treatment protocol? We have to also consider who is a candidate in terms of our patients, the cost, the availability to the patient, and then also is there going to be any discomfort? For my cryopreserved amniotic membrane candidates, I'm looking for, if the patient is monocular and I'm placing a tape tarsography and essentially the patient can't see anything out of that eye. In someone who's monocular and active, that maybe not be a practical option. For a patient who is monocular and sedentary, that might be a better option. Also, another clinical pearl is, you can also place these membranes in a sequential application. So what do I mean by that? Patient comes in with acute corneal disease, you place the membrane and you don't have 100% resolution after you've placed the first membrane. So what you can do is remove that membrane and then place another one until you're seeing an improvement or enough of an improvement where that acute corneal disease is starting to heal. And so that I reserve for my very severe, very difficult cases. And I, again, have had very good success with that. My recommendation here that I have learned throughout the years of using these membranes is that I typically like to implement them earlier in my protocol. I'm not waiting until the patient is in a refractory stage in their treatment. And I find that when we're seeing patients, we might be seeing these patients in the earlier disease, the stage of their disease. And so implementing these treatments for corneal nerve regeneration and epithelial healing might prevent further vision loss in the future. Okay, so let's keep on moving. We're going to be talking about neurotrophic keratitis and the treatment that we have available for it. So neurotrophic keratitis is a rare degenerative disease of the corneal nerves. It's characterized by a breakdown of the epithelium, persistent epithelial defect, stromal melt, and then eventually can lead to corneal perforation if not treated correctly. It's also characterized by a reduction or absence of corneal sensitivity, and it's thought to affect less than 65,000 individuals in the United States. Sometimes I feel that number, either they're all in my clinic, or sometimes I feel that number might be a little bit bigger than what we might think. And I'm interested to know what the studies show as we learn more about dry eye and neurotrophic keratitis. The corneal nerves and the corneal epithelium are again very important when it comes to mutually supporting each other. So when you're thinking about the development of NK in your patients, you really must be thinking that there is a significant loss of homeostasis here. So again, in the corneal nerves, you've got neuromediators that are providing that trophic support to the corneal epithelium, and that's through that wound healing, supporting wound healing and helping maintain that integrity of the cornea. The nerves need to be functioning well in order to support the epithelium. And then the epithelium, in turn, is going to provide the support to the corneal nerves, right? So we saw this slide before. In neurotrophic keratitis, there is a breakdown of this system, right? So the sensory input is damaged by damage to the trigeminal nerve and its branches, such as by chronic inflammation. This homeostasis that occurs between the nerves and the epithelium is altered, and then the epithelium becomes unable to heal. And that is the crux of what's happening in neurotrophic keratitis. So when dry eye becomes more moderate, as defined by the DEWS-2, with a breakdown in the corneal epithelium, so now we're looking right here in the moderate dry eye category, that's when we can start to see a degeneration of the corneal nerves in neurotrophic keratitis. Prolonged inflammation in dry eye, for example, it just drives this cycle of damage to the nerves, to the epithelium, to the nerves, to the epithelium. And that's when we start to progress to stages 2 and 3 in NK, and blinking and tearing reflexes are starting to break down. And again, we're losing that homeostasis on the ocular surface. We talked earlier about reduced corneal nerve density in dry eye and the possibility of regenerating those corneal nerves when we use biologics, such as amniotic membrane. So there is certainly some evidence that corneal nerve density is reduced in dry eye disease. This is a non-exhaustive list for the causes of neurotrophic keratitis. Again, you've got damage to the sensory input occurring to the trigeminal nerves. And that's not just from local conditions to the cornea and the anterior segment, but also systemic conditions that are causing loss of sensory input. So that's in diabetes. So if we polled everybody right now, every single person on this call has a patient in their clinic who has diabetes. Every person on this call has a patient in their clinic who has used topical medications for a prolonged period of time, especially with preservatives, has patients currently in their clinic with long-term history of contact lens use. Or has seen patients with keratoconus in the past. So there are many causes of neurotrophic keratitis, and a lot of that will overlap with dry eye disease, especially in the very, very, very early stages. So it's something to consider in your patients, that it's not just local disease, but it's also systemic disease as well. I love this slide. I think this is a great slide to save or screenshot. And the reason I love it is because it helps me localize the lesions. It helps me localize those causes for neurotrophic keratitis. Patients with, I want to make a note here that patients with progression in their diabetic disease are considered to be at a significant risk for developing neurotrophic keratitis because of that lack of healing component. So I do want you to keep that in mind when you are seeing progression of diabetic disease. So those patients who are progressing from non-proliferative to proliferative disease, especially in a short period of time. So the stages of neurotrophic keratitis and their classification was outlined way back when in 1995, and it's now widely known as the Mackey classification. So recent understanding of NK begs the question of, well, where does corneal sensitivity fit into this? And where does it fit into the clinical flow of making the diagnosis? So this classification here talks about the signs of neurotrophic keratitis. So here we've got stage 1. It's characterized by subepithelial corneal scarring. You might see some old scarring, maybe from an old hepatic corneal infection. You'll see some persistent SBK, maybe some corneal neovascularization. That then progresses on to a persistent epithelial defect, so that's PED in the cornea, with some stromal swelling and maybe even some folds in the Descemet's membrane. And then eventually that might progress to stage 3, which is characterized by a stromal melt and really looks like an impending perforation. So again, where do we bring corneal sensitivity testing into this? Well, with corneal sensitivity, what I would encourage you to do is think about 3 ways to test for corneal sensitivity. You can use a Cochet Bonnet if you have that available in your clinic. You can use unflavored dental floss, or you can use what I do, which is a cotton tip applicator. So I put on some gloves, I take that cotton tip applicator, and I kind of pull the wisps of the end of the cotton tip, and then without any eye drops, of course, so you're not instilling proparacaine before this test, and you're going to test each of 4 quadrants: superior temporal, superior nasal, inferior temporal, inferior nasal of the cornea, and then you're to document that as either present, partial, or absent. And what I would recommend is that if you are identifying that the patient has risk for NK, and then you're identifying that as part of your dry eye workup, then you certainly want to bring that patient back without anesthetic eye drops so that you can make a proper assessment of their corneal sensitivity. These are updated guidelines as of 2021 as to when to test for corneal sensitivity. And again, a really great slide to save as you are assessing your patients for these risk factors for developing NK. My personal experience is to implement this test early. So another clinical pearl here is that if you are identifying risk factors, patient has a scar and maybe has been using preserved latanoprost for glaucoma for a long time, and there are signs and there are symptoms of what you're seeing on the front of the eye is not matching up, and there's a disconnect between the signs and the symptoms where that patient doesn't have very many symptoms, but the cornea doesn't look very quite well, then I would certainly not wait for a long period of time before implementing this testing into your clinic. What about treatment? So the Mackey classification provides a really, really good guideline when it comes to diagnosing. But there are really no concrete guidelines for how to treat, right? Sounds like dry eye? Yes. So recently, a group using the Delphi panel method gathered to discuss the diagnosis, the treatment, and the inclusion of corneal sensitivity for NK. So here we see a very nice chart. We've got stage 1 and the signs of how to identify. So NK, that's going to be SPK, maybe that's persistent SPK. That's going to be in an interpebral or inferior staining pattern. You might see some superficial corneal neovascularization, as well as a reduced tear butt time and some of those other signs of dry eye. You will see either reduced or absent corneal sensitivity in at least one of the 4 quadrants in that eye. And the treatment, the consensus of the treatment seems to be, again, treating for dry eye, treating those comorbid conditions, right? As well as utilizing punctal plugs, bandage contact lens, removing any topical medications that have significant preservatives. And if that's not possible, then at least reducing the dosage, using gel tears and ointments, ensuring that there's no exposure, keratopathy that's happening, oral medications such as doxycycline, for the anti-inflammatory effects. And then as we progress to stage 2, we might be thinking autologous serum, amniotic membrane. We might be considering some surgical intervention at this point, depending on the severity, and Synegimen, which is now approved for the treatment of NK. And then as we progress to stage 3, this is going to be significantly more in the surgical realm. You might even consider a scleral lens for this patient, and they might even progress on to a corneal transplant. Again, Synegimen is an option here for these patients as well. So what is Synegimen? So let's talk a little bit about nerve growth factor before we understand what Synegimen is. So nerve growth factor was discovered very early on. It's an endogenous growth factor. It's made by the body, and it's expressed by multiple tissues of the eye: the retinal ganglion cells, the corneal epithelium, the stroma, the endothelium. It's considered to be neurotrophic and neuroprotective. Synegimen is recombinant human nerve growth factor. So it's structurally identical to nerve growth factor. Again, it's endogenous. It's really required to maintain corneal nerve health and regeneration. And there are receptors all over the eye, on the cornea, on the conjunctiva. Synegimen is approved for all stages of neurotrophic keratitis: stage 1, stage 2, stage 3. That's going to be very important as we progress in the talk. I do want to mention that phase 3 data is underway for stage 1 neurotrophic keratitis treatment. which is again very important. Let's talk about one of the major studies that we have that allows us to understand how effective Cenegimen can be in the treatment of neurotrophic keratitis. So the Reparo trial was the European trial, and what they did was they applied Cenegimen 0.002% ophthalmic solution 6 times a day, so about 1 drop every 2 hours for 8 weeks. The inclusion criteria was stage 2, so persistent epithelial defect, neurotrophic keratitis, or stage 3 neurotrophic keratitis. And what they found was that after 8 weeks of use, Cenegimen resulted in 72% of patients meeting those primary outcomes of a completely resolved epithelial defect and no corneal staining that was present. And then in the US study, the American study, we found very similar results with no epithelial defect and no corneal staining whatsoever, just 8 weeks after treatment. And then you might consider, well, what happens after 8 weeks? Well, they studied that too. So they looked at those patients 1 year after treatment, and what they found that 80% of those patients who had healed previously had maintained their results at 1 year out. So I think it's very important to consider not only the short-term effect of a treatment, but certainly the long-term control of neurotrophic keratitis as well. Neurotrophic keratitis, I think, is likely underdiagnosed in the early stages, and especially when it's concurrent with dry eye disease and there's multiple risk factors for chronic dry eye. We know that chronic dry eye might actually lead to neurotrophic keratitis, and there is definitely more data that's needed on the treatment of stage 1 NK. And so this study is underway. It was the abstract that was presented at the ARVO meeting 1.5 years ago. And I put this in here, I think it's so important because this is much like many treatments that come to market. We first see how efficacious they are when we're treating very severe disease, so stage 2, stage 3 NK. When we are in our clinics as primary care eye care providers, we are not likely seeing these patients at the first presentation at stage 3 neurotrophic keratitis. We are seeing these patients in the very early stages. So it's important that we're up to date and that we're understanding what studies are underway to help our patients in those early stages, because this is why we're in this business, so that we're preventing vision loss and preventing our patients from progressing in these disease states in the future. So this is a very dear patient to me. I want to talk to you about his case. This patient is a 90-year-old Hispanic male, comes into me. I've known him for about 5 years now, and he has very severe meibomian gland dysfunction, eyelid telangiectasias, and he presents with a very persistent band of SPK interpalpebrally and also very dense inferiorly. He has some very mild subepithelial opacification. He has an old herpetic scar. He also has a reduced blink rate as well. This patient had LASIK way more than 20 years ago. And he also is pseudophakic. So he's had some refractive procedures as well that may be interrupting the ability of his corneal nerves to heal. He's used latanoprost for a long period of time. And of course, to complicate things, he also has had type 2 diabetes for more than 20 years, largely uncontrolled. He's had multiple PRP treatments, focal treatments for macular edema, as well as intravitreal Avastin injections, for macular edema as well. So this patient, I started on nifitagrosd twice a day. He also has had multiple rounds of microblepharoexfoliation exfoliation and thermal pulsation for his blepharitis and meibomian gland dysfunction. He's had rounds of punctal plugs, oral doxycycline at a high dose, and then tapered for 3 months, occasional use of preservative-free tears. He stopped his latanoprost after having his cataracts taken out, but he certainly has long-term damage on his cornea. He's had multiple rounds of steroids. We've also pulsed treatments for him, and he has absent corneal sensitivity in all 4 quadrants in both eyes. So this is quite, I think, a severe case of dry eye and, of course, neurotrophic keratitis as well. He's had rounds of cryopreserved amniotic membrane, which he does very well with, but because we don't have long-term control, especially of his comorbid conditions. Obviously, they're requiring maintenance, where we don't really get a long-term solution for him. So this patient, I just started on Trigeminal 0.002%, and I'll be seeing this patient back in a few weeks. And I'm just so excited to see what improvement we see with him. Another consideration might be autologous serum, or maybe a combination of these treatments that we've talked about. So definitely Trigeminal, I think, plays a role. And I think that we should not be reserving this treatment for stage 2 and stage 3 only, but really thinking about how we might implement this again earlier in our protocol. What's the data that supports recombinant human nerve growth factor for corneal nerve regeneration? Well, there is a study that was published just less than 2 years ago that shows us that corneal sensitivity and density actually improves as measured by in vivo confocal microscopy with the use of recombinant human nerve growth factor, and I think that's very promising. What are the challenges? Well, there are significant challenges when it comes to making the diagnosis. These patients typically don't have very many symptoms. They don't have very many complaints. It's quite difficult to convince these patients, especially in the early disease process, that they need treatment. Lack of symptoms can delay care on their part. And also these patients might be misdiagnosed, especially in the early stages, and therefore it can affect the patient's follow-up. All right, so let's move on to our discussion of blood-derived eye drops, autologous serum eye drops, which I will refer to as ASEDs, and platelet-rich plasma eye drops, which I will refer to as PRP. So ASEDs are thought to be a very natural treatment for dry eye. Why do I say that? Well, they are typically preservative-free. They are very similar in the biomechanical and biochemical properties of our natural tears. So I'm talking about similar in pH and tear osmolarity, the content of proteins and vitamins and immunoglobulins and cytokines. And that's specifically with TGF-beta, epithelial growth factor, nerve growth factor, insulin-like nerve growth factor. And these are characterized or classified, currently as a third-tier treatment for dry eye. So there are some protocols out there, multiple protocols on how to extract ASEDs and PRP. And this is just one protocol that I will present to you. So typically you have a 50 to 100 milliliter blood draw for your ASEDs, and then your blood sits at room temperature to completely clot. This is very key. It's then centrifuged in order to separate the serum, which will be at the top, from the solid components of the blood. The supernatant is then diluted according to the concentration that the practitioner has recommended, and then it is processed in sterilized dropper bottles, frozen, and then shipped out to the patient. The concentrations as the practitioner, you can specify anywhere between 20% to 100%. Now, doctors ask me all the time, where do I start? What's the dosage? How many times a day, the frequency, the length of treatment. So I'm going to go ahead and share my experience with you, and hopefully you'll go away with some clinical pearls. I typically start at 6 times a day dosing at 40%, and that's for the first 3 months of treatment. After the first 3 months, if the patient is improving in the way that I would expect, if I've seen enough improvement where I feel comfortable tapering, I will go ahead and taper the frequency of dosing. If I don't see a significant improvement, we might either go on to another type of treatment, or we might continue in that vein for another 3 months, and that's a total of 6 months, and then taper. So it's really going to depend on the progression of the patient. Another key question I get from practitioners is, well, how do I access ASEDs? And I would recommend 2 things. Vital Tears is a company that's made it very easy for us. We then send the patient to a blood draw station in association with Vital Tears, and the patient has their blood draw there. The eye drops are then sent over to Vital Tears for processing and then sent directly to the patient. If that's not an option, or you decide not to go that way, you can certainly partner with a local lab or regenerative medicine clinic that's local in your area to assist with that preparation as well. Indications are very similar to the use of amniotic membranes and other treatments for dry eye and NK. And this is, again, certainly not a non-exhaustive list here. Contraindications, I will share an example with you. I had a patient who was undergoing concurrent chemotherapy for bladder cancer. And so in this patient, I specifically worked with Vital Tears. Again, no financial disclosures. I just find it easier to send my patients out there because that's organized very easily for the patient and for myself. So I spoke with the coordinator over there, and we were actually able to speak with the oncologist and pharmacist to coordinate the patient's blood draws 2 to 3 weeks after the chemo treatments. So certainly keep that in mind for patients who have an increase in pro-inflammatory cytokines in certain systemic diseases. Certainly not contraindication, but the draw and the use of autologous serum is very multidisciplinary. Let's talk about PRP. So one of the key differences between ACEDs and PRP is the use of platelets, okay, which contain the key growth factors that are needed to heal a sick cornea. So again, we start with our collection of whole blood, and instead of allowing it to clot, we actually don't want it to clot until it hits the cornea. So we add sodium citrate to it in a certain concentration and percentage, and that is the anticoagulant that prevents the clotting process. Allowing the blood to clot means that we're allowing the platelets to activate. And so we don't want that to do that. We don't want them to do that, excuse me, until they hit the cornea. Again, it's then centrifuged. And then we're going to see 3 distinct layers. We're going to see PPP, platelet poor plasma at the top, platelet-rich plasma, and then our white blood cells and our red blood cells at the bottom. The PRP, the platelet-rich plasma portion or fraction, is then aspired with a syringe and then transferred over to those sterilized dropper bottles for use. And so note that this is, again, another key factor. It's not diluted like autologous serum, and platelet-derived growth factor is thought to be one of the key components at play here. Again, accessibility, how do I get access to this? What my recommendation here would be is to partner with a local regenerative medicine clinic where patients can have their blood draws and those eye drops can be prepared for them. There are obviously challenges when it comes to blood-derived eye drops, right? So you might be thinking cost, availability, access, and then high maintenance and storage. Because we are dealing with biological human tissue here, there are no controlled trials. There's not really regulation on the concentration and the dosing, so that I completely appreciate can be difficult. There are certainly recommendations. My clinical pearl here would be to find doctors in your area who are using ACEDs and or PRP and have a discussion about some of those perceived barriers to care and whether you're able to implement this in your clinic. And if you are, I think that these are absolutely fantastic options for patients with advanced disease. So let's talk about a patient case here. This patient case will illustrate to you how to implement blood-derived eye drops into your clinic. So this is a 45-year-old Hispanic female. She has a history of rheumatoid arthritis for about 8 years. She's on hydroxychloroquine, 200 mg twice a day, Nexplanon, hormonal birth control, an oral antihistamine for allergies, as well as oral antihypertensives. So this is her initial presentation. This is her right eye. So obviously significant, very sick cornea, right? Significant diffuse coalesced SPK. The left eye is almost 85% covered in SPK. She also has some conjunctival staining here as well. So at this visit, I started her on step 1 hygiene for mild meibomian gland dysfunction and blepharitis. I put her on a topical steroid, QID, and cyclosporin 0.09% BID. We discussed step 1, environmental, dietary, and behavioral modifications. She's on an oral supplement, a dietary supplement of reesterified omega-3s, and we stopped using fans and ceiling vents and things like that. We stopped using any lotions, any creams around her eyes, and also started her on gel tears. She followed back with me in 2 weeks, and now she has filaments on her cornea. So I performed a thermal pulsation as well as a microblepharoexfoliation in the clinic, continued the steroid, added doxycycline, oral doxycycline for the inflammation, and the plan was to keep her on that for a month. Amniotic membrane wasn't available to this patient, and we don't have a ton of options when it comes to treating aqueous deficient dry eye in the United States. I started her on 40% autologous serum at 6 times a day dosing in both eyes. I wrote to her rheumatologist and asked if her RA was essentially controlled or whether there was any systemic inflammation that we had to keep in mind prior to recommending those ASEDs for her. She comes back a month later, and this is what she looks like. So let's break down these photos a little bit. So on the top left and the top right, you see her at initial presentation. 1 month after the treatments that I recommended for her, and of course on autologous serum, you're really starting to see some of this SPK heal, right? You're starting to see a significant improvement in the right eye and an absolutely magnificent improvement in her left eye just after 1 month. So at this point, she continues her cyclosporin 0.09%. I've stopped the steroids since. And she's obviously going to continue her ASEDs at 6 times a day, and then I'll see her back at the 3-month mark. At that point, if I'm still seeing a significant resolution or complete corneal healing, I might then taper her down rather than stopping the eye drops completely. And then we'll decide how long to keep her on her ASED treatment. And so this is a really great example of how to implement the treatment, but not wait too long, right? So in this case, I did not wait until, we had tried other treatments for her. I really wanted to get that nerve regeneration up and going, that corneal epithelium healing up and going. And so I really felt that ASEDs were the best option for her. So what's the data that supports the use of ASEDs and PRP in corneal nerve regeneration? Well, there was a very small study that was published a couple of years ago that supports corneal nerve regeneration in patients with corneal neuropathic pain. Okay, so we definitely need a lot more data, but we're starting to see some of this inclusion of in vivo confocal microscopy, where we can image the corneal nerves and understand the effect of our treatments when it comes to corneal nerve regeneration. There are definitely perceived barriers to care when it comes to implementing biologics into your dry eye treatment protocol. I would encourage you to consider implementing this treatment early, and also continue to layer your treatments as well. Where does the future of blood biologics lie? Well, I really thought that it was important to mention this here. Umbilical cord serum contains that unique proteoglycan matrix that I talked about earlier, and it's being used in surgical grafts so far with very good success, and it's something that we might see more widely used for the treatment of dry eye disease as well. So I'd like to poll you, please, where do you choose to implement biologics currently in your dry eye treatment protocol? Is it your first line of treatment typically? Is it when 1 to 3 therapies fail? Is it when more than 4 therapies fail? So we can certainly discuss the results of your poll during the Q&A. I want to say thank you so much to Dr. Fahmy for inviting me to speak today at this phenomenal event. I have thoroughly enjoyed the very innovative topics that we talked about. They've been very unique and very clinically applicable. Thank you so much for the entire team at the Eyes on Eye Care for their excellent organization. And I look forward to another great event in the future. If you have any questions, please feel free to email me or contact me on social media. Thank you so much.
Awesome. Hardeep, thank you so much for delivering this really important lecture. I want to dive right into it. So just a question for you to start right off the bat here is what does the clinic flow work like for you in corneal sensitivity testing in your dry eye service?
I think it's very important to start with corneal sensitivity testing early. So if you are suspecting that this patient has risk factors for developing neurotrophic keratitis, what I'll do is I'll schedule the patient back for an exam and specify to my technician workup team that I don't want the patient to have instilled any anesthetic, and then I'll just get right into it. As I'm looking at the cornea, and this is even on a first exam when a patient presents to me, if I'm seeing any of those risk factors, I will pull the plug pretty quickly on that.
And so including like the diagnostics, like tropicamide, like you want no drops in that eye if the patient's coming back for their dry eye eval?
That's exactly it. I don't want any eye drops in the eye. So typically we'll do tear lab testing and inflammatory testing. And we'll take IOPs and we'll do the vision. In this case, we'll do the vision. We won't do any eye drops, and I'll go straight into my corneal sensitivity testing.
Awesome. Now, can you also just kind of help us understand the biologics? It's such an important class of medications. How do you sort of determine in your mind who's going to benefit from this? Is this something we should be kind of waiting to prescribe for some time and just kind of holding on to it for a little bit until we see a certain severity level? Or is this something that we should introduce early on in our treatment plan?
I think this is a fantastic question. I think traditionally we perhaps have this mindset or this perspective that we should wait until a patient is quite severe because we have all these other list of treatment options available that we should work through before we get to the biologic options. And what I would encourage practitioners to consider, and something that I do in my clinic, is starting to implement these treatment options a lot earlier, sometimes even in my stage 2 treatments. And the reason I say that is because there's a huge indication when it comes to healing the epithelium and healing the corneal nerves and really having that ability to regenerate the corneal nerves. And I think if we can do that early in the treatment process, we can really avoid long-term damage to the nerves as well as progressive vision loss, which is, again, what I said in my lecture, that's why we're here. So definitely treating early rather than waiting, I think, is of huge value.
Yeah, perfect. Do you find that, that's really helped as far as some of these patients that might have more severe levels of dry eye to decrease the subepithelial haze in some of these patients long term?
I really do. I absolutely do, especially when I'm employing amniotic membranes and having some of those long-term eye drops like autologous serum. You're seeing these patients for a long time. These patients are coming back to you. They've been on preserved eye drops for glaucoma for years and years. And it's just a really important thing to start implementing these treatments early so that you can prevent things like subepithelial opacification.
Awesome. I know that, this is sort of really, flew by these quick questions, but I just really thank you so much for delivering what is an important talk and really should be a part of every, ocular surface disease, line of service. I really appreciate you taking on this talk. Just a quick couple of announcements. I want you guys to also navigate to the implementation in the exhibit halls. We have some awesome content happening on the other side as well. Dennis Evans from Dry Eye Rescue, and then also Dr. Amy Now and Jeff Sensino are going to be talking about MGD and keratoconus. Dr. Hardeep Kataria, thank you so much for joining my faculty this year. You did a super job.
Thank you so much. I hope everybody enjoys the rest of the show.
Absolutely.
Thank you.
Thank you so much.